General principles of benzodiazepine tapering. When benzodiazepines have been used beyond the recommended short term, 2 to 6 weeks, abrupt discontinuation can provoke withdrawal symptoms including rebound anxiety, insomnia, agitation, seizures, and, in severe cases, delirium. Therefore, a structured, gradual taper is essential. The rate of taper should be guided by the duration of prior use, the daily dose, the specific agent, especially its half-life, and individual patient factors such as age, comorbid conditions, and history of withdrawal or seizure disorders. A commonly cited general taper schedule is as follows. Reduce the total daily dose by 25% per week until 50% of the original dose is reached. Thereafter, decrease by 1/8, 12.5%, of the original dose every 4 to 7 days until discontinuation. This two-phase approach allows a more rapid initial reduction when receptor occupancy is still high, followed by a slower, finer titration to minimize withdrawal symptoms at lower doses. However, the total taper duration should be tailored to the length of benzodiazepine use. Duration of use. Recommended taper duration. 8 weeks, but 6 months. 2 to 3 weeks. 6 months, but less than 1 year. 4 to 8 weeks. Greater than 1 year. 2 to 4 months, slow taper. These time frames represent the total taper period, not the interval between dose reductions. The best taper strategy? The best strategy is not a single fixed schedule, but an individualized, patient-centered approach that combines the above guidelines with clinical flexibility. Key considerations include half-life of the benzodiazepine, long-acting agents, e.g., diazepam, chlordiazepoxide, produce a more gradual decline in blood levels, often allowing slightly faster percentage reductions or a smoother taper overall. Short-acting agents, e.g., alprazolam, lorazepam, are associated with more intense interdose withdrawal. Switching to an equivalent dose of a long-acting benzodiazepine, diazepam conversion, is often preferred, especially for patients who have been on short-acting drugs for many months or years. Patient-specific factors. Previous withdrawal history. Patients who have failed prior tapers may need a slower, more conservative schedule, e.g., 5 to 10% reduction every 1 to 2 weeks. Comorbidities. Hepatic impairment slows metabolism of long-acting agents. Renal impairment affects water-soluble benzodiazepines like lorazepam and oxazepam. Concurrent CNS depressants. Alcohol or opioid use increases withdrawal risk and should be addressed before or during taper. Psychological readiness. High anxiety or lack of non-pharmacologic coping skills may necessitate a slower taper with adjunctive cognitive behavioral therapy. Monitoring and adjustment. The best strategy is response-guided. If withdrawal symptoms emerge, e.g., tremor, tachycardia, insomnia, panic, hold the current dose for an additional week or revert to the previous dose. Then proceed with a smaller decrement, e.g., 10% instead of 25%. Conversely, if the patient tolerates reductions well, the taper can be accelerated cautiously, but never faster than the upper limit of the recommended schedule. Best taper strategy. Step 1. Choose the total taper duration based on duration of use, e.g., 2 to 3 weeks for 8 to 24 weeks of use, 2 to 4 months for greater than 1 year. Step 2. Convert to a long-acting benzodiazepine, if appropriate. For patients on short-acting agents, alprazolam, lorazepam, triazolam, for 6 months, consider switching to an equivalent dose of diazepam using standard conversion tables, e.g., 0.5 mg alprazolam is almost equal to 10 mg diazepam. This produces smoother blood levels and fewer interdose symptoms. Step 3. Apply the two-phase percentage reduction. Phase 1, first half of the taper. Reduce by 25% of the original dose each week until 50% of the original dose is reached. Example, starting dose equals 20 mg diazepam/day. Week 1, 15 mg/day, 25% reduction. Week 2, 10 mg/day, another 25% reduction from original. Phase 2, second half. Reduce by 1/8, 12.5%, of the original dose every 4 to 7 days. From 10 mg per day, Reduce by 2.5 milligrams, 12.5% of 20 milligrams. Every 4 to 7 days, 7.5 milligrams, then 5 milligrams, then 2.5 milligrams, then 0. Step 4. Adjust total duration to match the recommended taper length. The percentage schedule above yields a total taper of approximately 6 to 8 weeks, 2 weekly reductions in phase 1 plus 4 weekly reductions in phase 2. If the recommended duration is shorter, e.g., 2 to 3 weeks for 8 weeks of use, the same percentage steps can be taken every 2 to 3 days instead of weekly. If the recommended duration is longer, e.g., for months for greater than 1 year of use, the same percentage steps can be spread out over 14 to 21 days each, or use smaller decrements, e.g., 10% every 1 to 2 weeks. Step 5. Individualize. For elderly patients or those with significant comorbid illness, use a slower taper, e.g., extend each step to 2 weeks, or use 10% reductions. For patients with a history of seizures or on anticonvulsants that lower seizure threshold, taper more conservatively and consider adjunctive anticonvulsant therapy if needed. Step 6. Adjunctive support. Offer psychoeducation about withdrawal symptoms. They are temporary and not dangerous in a controlled taper. Consider adding melatonin for sleep, hydroxyzine or buspirone for anxiety, or cognitive behavioral therapy for insomnia, CBTI, to address the underlying condition that originally required the benzodiazepine.